This podcast is hosted by Will Glomsky. Will is an experienced critical care paramedic working on a ground ambulance. This podcast is purely educational, and the opinions reflected are of the hosts only. This show is not intended to supersede any local protocol or training. This podcast covers educational content surrounding emergency medical services. Welcome to the Midnight Medic Podcast.
Hello and welcome to another episode of the Midnight Medic Podcast, the podcast for emergency medical service professionals committed to excellence in pre-hospital care. I'm Will, and today we're tackling a topic that's both common and critical in our line of work, congestive heart failure or CHF. As EMS providers, our swift recognition and management of CHF can make all the difference for our patients. So let's dive into the essentials of pre-hospital treatment for CHF. What is congestive heart failure? Congestive heart failure is a condition in which the heart's ability to pump blood effectively is compromised. This can lead to a buildup of fluid in the lungs, extremities, or other parts of the body. CHF can be classified into three different types. Left-sided heart failure, which results in pulmonary congestion and symptoms like shortness of breath and crackles on auscultation. Right-sided heart failure, which leads to systemic venous congestion, presenting as peripheral edema, ascites, and jugular venous distension, or acute decompensated heart failure, which is a sudden worsening of CHF symptoms, often the reason for a 911 call. Causes and risk factors. CHF doesn't occur in isolation. It's often the result of underlying conditions, such as coronary artery disease, hypertension, myocardial infarction, valvular heart disease, arrhythmias, especially atrial fibrillation, cardiomyopathies, and lifestyle factors like smoking, obesity, or high salt intake. Recognizing these factors can provide context for your patient's presentation and help tailor your treatment. Signs and symptoms. In the field, CHF can present in various ways, but common symptoms include dyspnea, often worse on exertion or when lying flat, which is called orthopnea, paroxysmal nocturnal dyspnea, sudden shortness of breath during sleep, crackles or rales, indicative of fluid in the lungs, peripheral edema, swelling in the legs and feet, jugular venous distension, a hallmark of right-sided heart failure, tachycardia and hypertension, often present in acute cases, cyanosis or pallor, signs of poor oxygenation, and fatigue and weakness due to decreased cardiac output. Pre-hospital assessment. When you suspect CHF, a thorough assessment is crucial to guiding your interventions and determining the urgency of transport. Here's how to structure your assessment. Primary survey. Begin by ensuring airway patency, adequate breathing, and circulation. Address any immediate life threats, such as severe respiratory distress or shock. Evaluate the level of consciousness to help identify signs of hypoxia or poor perfusion. Focus history. Chief complaint. Ask the patient to describe their symptoms, focusing on onset, duration, and severity of shortness of breath, fatigue, or chest discomfort. Medical history. Determine if the patient has a history of CHF, hypertension, coronary artery disease, or arrhythmias. Medications. Ask about prescribed medications such as diuretics, ACE inhibitors, beta blockers, or recent changes in dosage. Triggers. Explore potential precipitating factors such as dietary indiscretion, also known as high sodium intake, noncompliance with medications, recent infections, or physical overexertion. Physical exam. Lung sounds. Auscultate for crackles or rales, which suggest pulmonary edema. Wheezing may indicate bronchospasm secondary to fluid overload. Cardiac assessment. Check for the presence of an S3 gallop, which is often associated with CHF. Peripheral edema. Inspect the lower extremities for pitting edema, a hallmark of fluid retention. Or JVD, assess the patient at a 45-degree angle. JVD indicates elevated central venous pressure. Skin condition. Look for signs of poor perfusion, such as cool, clammy, or cyanotic skin. Vital signs. Hypertension is common in early decompensation, while hypotension may indicate cardiogenic shock. Tachycardia may signal compensation for reduced cardiac output, whereas bradycardia can indicate advanced disease. Tachypnea is often present due to hypoxia and increased work of breathing. Measure pulse ox. SpO2 below 90% typically requires supplemental oxygen. ECG. Perform a 12-lead ECG to evaluate for ischemic changes, arrhythmias, or signs of left ventricular hypertrophy or strain. Look for signs of ischemia or infarction, such as ST segment changes, which could indicate acute coronary syndrome contributing to the patient's decompensation. Assess for arrhythmias, such as atrial fibrillation or ventricular tachycardia, which are common in CHF and may require specific interventions. Identify patterns of left ventricular hypertrophy or strain often seen in patients with chronic hypertension and CHF. Monitor for low-voltage QRS complexes, which may suggest pericardial effusion or severe pulmonary edema. Use capnography, if available, to assess respiratory status. An elevated end-tidal CO2 or a rising waveform can indicate hypoventilation. If the patient has a known history of CHF, ask about recent weight changes as an indicator of fluid retention. Pre-hospital treatment of CHF. Managing CHF in the field revolves around stabilizing the patient and alleviating symptoms. Let's break it down step by step. Airway management. Ensure the airway is open and clear. Position the patient upright to reduce preload and improve breathing. Suction if the patient has frothy sputum. Oxygen therapy. Administer oxygen to maintain SpO2 levels above 90%. Use a non-rebreather mask for severe hypoxia, or consider CPAP for pulmonary edema and respiratory distress. CPAP, or continuous positive airway pressure, is a game changer in CHF management. CPAP improves oxygenation and reduces the work of breathing by forcing fluid out of the alveoli. Start at low pressures, 5 to 10 centimeters of water, and titrate based on patient response and comfort. Monitor for hypotension, as CPAP can reduce preload and blood pressure. Administer sublingual nitroglycerin if the patient is hypertensive and doesn't have contraindications like hypotension or recent phosphodiesterase inhibitor use. Nitroglycerin reduces preload by dilating venous blood vessels, which decrease the amount of blood returning to the heart, alleviating pulmonary congestion. It also reduces afterload by dilating arterial vessels, easing the workload on the heart. Typical dosing includes 0.3 to 0.6 milligrams sublingually every 5 minutes as needed, ensuring blood pressure remains above protocol thresholds, which are usually around 100 to 140 milligrams of mercury systolic. For severe cases, some protocols allow for IV nitroglycerin infusion under medical direction, enabling precise titration to achieve desired hemodynamic effects. Monitor for potential side effects such as headache, dizziness, or hypotension, and adjust treatment accordingly. Diuretics. Diuretics like furosemide or Lasix are often included in protocols to reduce fluid overload. Administer cautiously, especially in pre-hospital settings, as overdiuresis can lead to hypotension and electrolyte imbalance. Typical dosing ranges from 20 to 40 milligrams IV, depending on the patient's history and current condition. Be aware of the delayed onset of action. Diuretics may not provide immediate relief, but are essential in longer-term fluid management. Monitor for side effects such as dehydration, hypokalemia, and worsening renal function, particularly in elderly or frail patients. IV access and monitoring. Establish IV access for medication administration and fluid management. Continuously monitor vital signs, especially blood pressure and heart rate. In severe cases of respiratory failure or unresponsiveness, endotracheal intubation may be necessary. Ensure proper sedation and paralytics at performing RSI. Transport decisions. Expedite transport to an appropriate facility, particularly one with cardiology and critical care capabilities. Pitfalls to avoid. Avoid aggressive fluid administration unless absolutely necessary. CHF is a volume overload state, and additional fluids can exacerbate pulmonary edema. Be cautious with opioids for dyspnea, as they can depress respiration. Don't delay transport for extended on-scene treatment. Monitor blood pressure closely when using nitroglycerin or diuretics to avoid precipitous drops leading to hypoperfusion. Avoid assuming all dyspnea in CHF patients is due to fluid overload. Consider alternative or coexisting diagnoses such as pneumonia or pulmonary embolism. While our focus is on stabilization, it's helpful to understand what's next for our CHF patients. Inotropes. Medications like dobutamine may be used to improve cardiac output in severe cases. Advanced imaging, echocardiography, helps assess heart function and identify structural issues. Cardiac catheterization for patients with ischemic causes of CHF, and ultrafiltration, a technique used to remove excess fluid in patients resistant to diuretics. Preventing CHF exacerbations. Education and prevention are key to reducing 911 calls for CHF. Encourage patients to adhere to low-sodium diets, take medications as prescribed, including diuretics and beta blockers, and monitor weight daily and report sudden weight gains, and follow up with their cardiologist regularly. Congestive heart failure is a complex condition that demands quick thinking and skilled intervention. As EMS providers, we play a critical role in breaking the cycle of exacerbations by providing timely, evidence-based care. Remember, your actions in the field can significantly influence outcomes and quality of life for CHF patients. That wraps up our deep dive into the EMS management of congestive heart failure. By recognizing the science, providing timely interventions, and prioritizing transport, we play a vital role in improving outcomes for these patients. If you found today's episode valuable, share it with your colleagues, and don't forget to subscribe for more insights tailored towards EMS professionals. Thank you for tuning in to the Midnight Medic Podcast.